Hi everyone. Um, Welcome to your endoscopy weekly teaching. My name is Dr. Stephen Fong. I'm one of the gastro consultants here at the Conquest. For today's topic, we're going to be talking about anticoagulation before and after endoscopy, when to start it, when to stop it. So this is quite an important topic, obviously, for many reasons. Obviously, there are a lot of patients who are anticoagulated, and it is very important that you know when to start and when to stop. A few key lessons I think to take home is that you should always follow the BSG guidelines about anticoagulation and endoscopy. They are quite informative and they have very clear pathways. It's important as doctors or nurses to realize that assessing the risks of whether you can stop anticoagulation or whether you need to give Clexane cover can be complicated. For example, in atrial fibrillation, you need to look for high and low risk factors. And so it is not as simple as asking your doctor whether to start or stop, and get an answer straight away. So little tips, get as much information to inform your risk assessment when you're trying to decide. Both endoscopists and nurses have to take responsibility for doing the right risk assessment to decide whether to start and stop. So I'm going to now play a video which comes from the United European Gastro Week conference, which gives a very good overview of this.
Procedural anticoagulation, when to start and when to stop. First of all, I have nothing to declare. There are mainly two types of anticoagulants. The DOAC, the non-vitamin K oral anticoagulants, and the vitamin K oral anticoagulants, warfarin and fenbrocomon. Dealing with Peri procedural anticoagulation, some general considerations have to be made. What is the underlying disease? Is it a patient with a mechanical heart valve? Is it a patient with atrial fibrillation? Is it a patient with venous thromboembolism in his past? And you have to deal with the individual thromboembolic risk. Is it high or is it low? And you have to deal with the bleeding risk. There is an individual bleeding risk, and the bleeding risk depends on the procedure. Is it a high risk or is it a low risk procedure? The individual thromboembolic risk is very well defined. There are high risk conditions concerning venous thromboembolism and mechanical heart valves as listed in this slide. A prosthetic metal heart valve in mitral position, for example, is an individual high thromboembolic risk, or a venous thromboembolism in the last 3 months. The individual thromboembolic risk in patients with atrial fibrillation is shown in mainly two scores, the JETS 2 West score and the JETS 2 score. A JETS 2 West score of more than 7 points means a high individual thromboembolic risk and an adjusted stroke rate of more than 10% a year. The individual bleeding risk is not so easy to define. There are non-modifiable factors and modifiable factors. For sure, severe renal impairment in patients taking DOAC is a high individual bleeding risk factor. The estimated drug half-life for dabigatran in patients with creatinine clearance from 15 to 29 is 27 hours. There is a guideline from the ESGE from 2016 with a good overview of high-risk procedures and low-risk procedures. A polybectomy, for sure, is a high-risk procedure, and a diagnostic colonoscopy with or without biopsy is classified as a low-risk procedure. There is a study from Japan dealing with the safety of gastrointestinal endoscopic biopsy in patients taking antithrombotics, and the need for endoscopic hemostasis after biopsy was not higher in patients taking antithrombotics compared to a control group, even in patients with an ENR bigger than 3. The ESGE recommends in patients taking DOAC and receiving a high-risk procedure to take the last dose of the drug at least 48 hours before procedure, with one exception: patients with dabigatran therapy, a creatinine clearance from less than 50, receiving a high-risk procedure. The last dose should be taken at least 72 hours before procedure. And this DOAC therapy interruption protocol is very similar to a DOAC therapy interruption protocol published in JAMA in 2019, dealing with patients with atrial fibrillation. Only one significant difference: patients with dabigatran intake, creatinine clearance of less than 50, receiving a high-risk procedure. Dabigatran should be stopped 96 hours before procedure. The rate of perioperative major bleeding and arterial thromboembolism were very low in this study. So the DOAC therapy interruption protocol is a good thing. The study has one limitation: the mean CHATS-2 score was only 2, about 2. Dealing with patients receiving fenbrocomon or warfarin and a high-risk procedure, it is dependent on the low-risk or high-risk condition. A low-risk condition, for example, is atrial fibrillation without valvular disease. The high-risk conditions were listed in a slide before. In patients taking warfarin and receiving a high-risk procedure with a low-risk condition, warfarin should be stopped 5 days before endoscopy. Patients taking warfarin and receiving a high-risk procedure, which are in a high-risk condition, warfarin should be stopped 5 days before endoscopy, and a bridging therapy using low molecular weight heparin 2 days after stopping warfarin should be initiated. The so-called bridging therapy is examined in several studies. There is the BRIDGE trial published in New England Journal of Medicine, dealing again with patients with atrial fibrillation. The incidence of arterial thromboembolism was very low in the bridging therapy group and in the control group, the incidence of major bleeding was for sure significantly higher in the bridging therapy group compared to the control group. There are two possible limitations of the bridge trial. Again, the mean CHADS-2 score was about 2, and the patients were receiving mainly low-risk procedures. Another study dealing with bridging is out of the Swedish anticoagulation register. And patients with atrial fibrillation, with mechanical heart valves, and after-venous thromboembolism were included. Surprisingly, in the bridging therapy group, there was a higher rate of thrombotic events, perhaps due to performing bridging therapy in low-risk procedures.
So to be honest, it's free flow.
When to start after a high-risk procedure?
No, it's all good.
Patients with DOAC. The DOAC should be restarted on day 2 after performing procedure. Dealing with patients with vitamin K oral anticoagulants, warfarin or fenbrocomon should be restarted on the evening of procedure or on day 1. And in terms of bridging therapy, low molecular weight heparin should be restarted on day 2 after procedure until ENR is therapeutic. The Peri procedural management of patients receiving a low-risk procedure is shown in this slide. Dealing with patients with DOAC therapy, the DOAC should be omitted on the morning of procedure. So I make a summary. It is necessary to make a difference between patients with DOAC therapy or warfarin therapy. It is necessary to calculate the individual thromboembolic risk, and it is necessary to know if it is a low risk or a high risk procedure. Thank you.
Thank you very much. And I think this is
I'm just recording this session for the endoscopy nurses teaching.